With the management of heart failure, recent updates. This actually is a recent update, a recent definition from the American Heart Association 2021 guideline. So heart failure is a clinical syndrome with symptoms and or signs caused by a structural and or functional cardiac abnormality and corroborated by elevated natriuretic peptide levels and or objective evidence of pulmonary or systemic condition. So before going to the management, I just want to just brief on the stages of heart failure. The stage A, that is the patients at risk for heart failure. That is those who have risk for heart failure. That is patients with hypertension, cardiovascular disease, diabetes, and all. So these patients never had any symptoms or signs of heart failure. So they are more prone for developing heart failure in the future. So stage B, these patients without current or previous symptoms, but they have structural disease like left ventricular hypertrophy, increased filling pressures, and other risk factors. And that is increased natriuretic peptide levels or cardiac troponin in the absence of competing diagnosis. And stage C, patients with current symptoms as well as the structural changes. And stage D is advanced heart failure. So next to diagnosis, always diagnosis based on the clinical history, clinical examination, and lab reports. Clinically, we have to assess the clinical signs of heart failure like elevated JVP, any additional heart sounds like ES3, basal crepitation, so a lot of clinical scenarios. Then we have to go for the natriuretic peptide levels, then transthoracic echocardiogram. And here we have confirmed the diagnosis, and then we have to classify the heart failure depends on the ejection fraction. So the heart failure with reduced ejection fraction, that is EF less than 40%, and 41 to 49% is the ejection fraction, mildly reduced ejection fraction category. And then the heart failure with preserved ejection fraction, that is the EF more than 50%. Coming to the causes of heart failure, there is risk factors like hypertension, obesity, prediabetes, and atherosclerotic cardiovascular diseases. And then, of course, the ischemic heart disease and myocardial infarction, the most common thing. And then the non-ischemic causes like chemotherapy, rheumatologic or autoimmune, endocrine, and all. So the coming to recommendations for patients at risk of heart failure and pre-heart failure. That is, we'll start with stage A. That is here the primary prevention. That is, patients with hypertension, we have to optimize the medicine and we need the optimal control of blood pressure by the medications. And the patients with type 2 diabetes and cardiovascular disease or high risk of CVD, SGLT2 inhibitors are the choice. And patients with cardiovascular disease, optimal medical management. And patients have any exposure to cardiotoxic agents, there should be a multidisciplinary action. And definitely genetic counseling, genetic screening and counseling is needed if any first degree relatives of the patients with genetic or inherited cardiomyopathy. And natriuretic peptide screening is a 2A indications. And coming to the stage B, that is preventing this syndrome. So patients with ejection fraction less than 40%, the choice is ACE inhibitors. And patients with recent MI and ejection fraction less than 40%, AC or ARB. If there is any intolerance to ACE inhibitors, ARB is the choice. Then of course beta blockers, and ICD is indicated if the ejection fraction less than 30% and more than 1 year survival. In MI patients, post-MI period of 40 days. And genetic counseling for cardiomyopathies. Then coming to the treatment strategies of stages C and D. Here, we need a stepwise approach for the treatment. Here, the ejection fraction is less than 40%. Definitely, RNA, that is the angiotensin receptor natriuretic inhibitor in NUHA 2 to 3, and AC inhibitors or ARBs in NUHA 2 to 4. Then, of course, beta blockers, mineralocortical receptor antagonists, SGLT2 inhibitors, and diuretic if needed. Don't use diuretic left and right because this diuretic has a lot of side effects. It can cause electrolyte imbalance, dehydration, so a lot of things. So you should be very cautious while using diuretic. If any congestion, any signs of heart failure congestion, definitely you can start this diuretic. Then coming to the step 2, we have to titrate the maximum tolerable doses of the drugs. Then coming to step 3, that is here we have to consider these patient scenarios. There is, we have a lot of trials regarding this. If any African Americans, especially in the class 3 to 4, it have shown that nitrates along with hydrolysin have some benefit. So here definitely depends on the clinical scenarios of the patients. Then initial class 1 to 3 and ejection fraction less than 35% and more than 1 year survival. Then you can go for the ICD. And definitely electrocardiogram shows left bundle branch blocked with a QRS duration of more than 150 milliseconds. We can think about CRTD. And then, of course, if the patient is a refractory heart failure, that is stage D, and symptoms improves, definitely you can go with guideline-directed medical therapy. And if it is still symptoms persist, then you can go for the left ventricular assist devices, and finally end up in cardiac transplant. These are additional medical therapies after this guideline-directed medical optimization. Here comes the ivabradine, that's the 2A indication. And patients here, actually patients with ejection fraction less than 30%, those who are in sinus rhythm, and we are not able to maintain the heart rate because this actually mainly affect on the function, that is a sinus node. So if patient is on maximal tolerable doses of beta blockers and still we can't control the heart rate, you can introduce ivabradine 5 milligram BID and up to 7.5 milligram BID. Then where is it got? Actually, I have less experience with this drug because Oman it's not available. I think one of our colleagues who are working in India, maybe they are more familiar with that. So we can start this drug with 2.5 milligram QAD and 10 up to 10 milligram QAD. And coming to the digoxin, which is an old drug, have some benefits, means there is no mortality benefit, but it will reduce recurrent hospital admissions. So we can use it. And regarding this polyunsaturated fatty acids, the 2B indications, and also the potassium binders, if there is any hyperkalemia, more than 5.5. Then the recommendations for patients with mildly reduced ejection fraction, diuretic definitely as needed, as I mentioned before. Then the SGLT2 inhibitors, AC, ARB, or ARNI, that is sacubitril valsartan compression 2B indication. Then the mineralocorticoid receptor antagonist, and definitely evidence-based beta blockers for heart failure with reduced ejection fraction. And recommendations for patients with preserved ejection fraction, diuretics if needed, then SGLT2 inhibitors, ARNI, the mineralocorticoid receptor antagonist, and ARBs. Coming to the non-pharmacological management of advanced heart failure, that is a 2B recommendation. So for patients with advanced heart failure and hyponatremia, the benefit of fluid restriction to reduce congestive symptoms is uncertain. Coming to the devices, left ventricular assist device, there are strong indications where we can use this device. The patient, those who have frequent hospital admissions with a short span of time, a lot of patients are with severe heart failure, especially class 3 and 4 patients. They have recurrent hospital admissions within a short period of time. These are the apt patients for device therapy. That is, NVH 3B to 4 symptoms, despite maximal guideline-directed medical therapy or intolerance to this medical therapy, you can think about ventricular assist device. It is not that simple and easy available, and it's very costly. Some of them are the heart made by US companies and Sputnik by the Russian companies. Sputnik is a little cheaper, but still it costs around 40 lakhs rupees. So it is very difficult to manage for middle income patients. But definitely it has a role for heart failure, and normally we use this as a bridge to cardiac transplant, and finally cardiac transplantation. So cardiac transplantation, the median survival of other transplant recipients is more than 12 years, versus less than 2 years only survival for patients with stage D heart failure without advanced therapies. So definitely cardiac transplantation is a good option, but it has the technical difficulties because the availability. And coming to the recommendations for management of atrial fibrillation in heart failure. So patients with chronic heart failure with permanent, persistent paroxysmal atrial fibrillation and a Charles Wall score more than 2 in male and more than 3 for women should receive chronic anticoagulation therapy. And for patients with chronic heart failure with permanent persistent paroxysmal AF, direct oral anticoagulation is recommended over warfarin in eligible patients. And radio frequency ablation is recommended as a 2A recommendation, but there's a chance of recurrence, especially for patients with heart failure. The recommendation for heart failure in pregnancy in women with a history of heart failure or cardiomyopathy, including previous peripartum cardiomyopathy, definitely this importance for counseling not to get pregnant again because the mortality of peripartum cardiomyopathy is recurrence is there and the mortality is very high. And in women with acute heart failure caused by pericardial cardiomyopathy, that is ejection fraction less than 30%, anticoagulation may be reasonable at diagnosis until 6 to 8 weeks of postpartum. And also, you should keep in mind that in women with heart failure or cardiomyopathy who are pregnant or currently planning for pregnancy, all the drugs which will get benefits in heart failure, like sacubitril valsartan or ACE inhibitors or ARBs, are contraindicated in pregnancy because this can harm the baby. So these are the guideline direct medical therapy and the scenarios. But what's the current scenario, practical approach actually? This actually, we done a study in our institution when I done my post graduation in a couple of years back in the Kerala Institute of Medical Science with my professor Vijay Rakhan. We did a study on around 280 patients with heart failure stage 3 and 4, and we divide the group into two, that is ischemic and non-ischemic heart failure. You see how many percentage of patients are getting this optimal medical therapy. In first group only 18.4 and second group only around 18. So it comes around 38 to 40% of patients only got this optimal medical therapy because of these contraindications. So why they are not getting this? What are the reasons? What are the contraindications to use these beneficial drugs? That actually we published in our own journal of IACC, that is Annals of Clinical Cardiology in 2020. See, these are the reasons why they are not getting this drug. We are like we are not able to give this drug because of renal failure, progressive renal failure. Renal failure is not a contraindication for ACE inhibitors or ARVs, but there's a progressive renal failure. Definitely, we have to stop these drugs. Then hyperkalemia is an absolute contraindication for using these drugs, and hypotension. So these are the clinical scenarios. So treatment guidelines are there, a lot of beneficial drugs are there, we have trials, but this current scenario, this is the result. So heart failure is not an easy task to treat it, so better to prevent all these things. Thank you for the patient listening.
Thank you so much, Dr. Suman. That was a lucid presentation. Any questions for Dr. Suman? Any comments for Dr. Suman? I would like to ask something. In the present scenario, when we have so many drugs for heart failure, specifically after SGLT2 inhibitors and sacubitril valsartan combination, where do you place diuretics, the loop diuretics or the potassium sparing diuretics? Where do you place them in management of heart failure?
See, it depends on the clinical scenarios. No, diuretics are only indicated where there is any condition, definitely. Otherwise, all the other beneficial drugs, like because the diuretic never had any mortality benefits, only that will improve the symptom for the symptom relief, especially congestion. So all the other drugs, the like ARNI, that is sacubitril valsartan, AC or ARBs are the choices. But definitely, in the guidelines says that you can also start with this. You can add with this diuretic mineralocorticoid receptors. Depends upon the renal function, potassium, and all. But definitely, this mineralocorticoid receptors also get some benefits. We have trials, top cards trial. So definitely it's benefits and depends upon the renal status, potassium levels. Definitely we can add all these drugs.
Is there any role of thiazide type diuretics in heart failure management?
There is no role for thiazide diuretics in heart failure.
Symptomatic relief? Symptomatic relief?
No. I think
Suppose a patient is a low weight patient and not able to tolerate even low dose of loop diuretics. In that situation, for symptomatic benefit,
actually, this is beneficial. See, we have different categories, 1 to 4. No, for the class 1 and 2, definitely you get benefits because what we tell initial, the risk factors are hypertension. So controlling hypertension itself, we say like treating heart failure. They are more prone, they have more risk for developing heart failure in the future. So definitely for controlling of hypertension, definitely there's a role, especially thiazide diuretics and chlorothalidone, all the things. Definitely trials have proven that, of course.
Thank you. Thank you so much. Any other questions, any comments for Dr. Suman OS?
I'm Dr. Avnendra. I just want to say that thiazide-like diuretics have a role in, forced diuresis in patients who are, when you have started decongestive therapy and they're still not responding adequately, you can add metalazone 2.5 or 5 mg just within 20 minutes after giving injection furosemide or something, and they have a forced diuresis. They have it can help in the decongestive part of the treatment of heart failure.